Okay, we're about a minute past. So welcome everyone. Thanks so much for joining today. And today we have Dr. Rebecca Aslakson presenting on Lessons Learned, Victories Celebrated, and Scars Acknowledged, the lumps and bumps of designing, funding, and leading palliative care clinical trials in cancer surgery. So just a couple reminders, you're muted and your video cannot be turned on. However, we wish for you to engage with us by typing your thoughts into the chat and your questions in the Q&A feature, which is a button in your Zoom toolbar. So on the panel, we also have Dr. Christine Ritchie, co-chair of the PCRC. And so I'd like to turn it over to Dr. Ritchie to ask that she please formally introduce our speaker.
Thank you, Naomi, and greetings, everyone. We're so glad to have you here today. I'm also really happy to introduce to you Dr. Rebecca Aslakson. Many of you probably know Dr. Aslakson, but actually it's really fun to tell you a little bit about her. So she's triple boarded in critical care, anesthesia, and hospice and palliative medicine. And if that wasn't enough, she also has a PhD in clinical research and is really devoted to an academic career to improving the delivery of effective and equitable palliative care interventions, especially to surgical and critical care populations. She's led many studies, you'll hear about some of them today, with awards from a number of funders, the Patient-Centered Outcomes Research Institute, the Agency for Healthcare Research and Quality, Gordon Betty Moore Foundation, the National Palliative Care Research Center, Foundation for Anesthesia Education and Research, has over 80 publications and has received lots of awards for her work, including the 2014 American Society of Anesthesiologists Presidential Scholar Award, the 2015 FAAHPM Early Investigator Award, and also the 2016 Inspiring 40 Under 40 Leaders in Palliative Care. She is a newly minted chair in the Department of Anesthesiology at the University of Vermont Larner School College of Medicine and across the 6 Hospital University of Vermont Health Network. She now lives in Burlington, Vermont with her husband, their sons, and 2 beloved rescue dogs. So, Rebecca, we're so happy to have you, and we look forward to learning from you today.
Christine, thank you so much. What a lovely introduction. Yes, we do love our little dogs. They're small but mighty. So it's great. I'm excited to be here today. I'm ready. I wore short sleeves today because I'm going to show you my scars a little bit of definitely lumps and bumps, and there are successes, but also just being honest about the challenges, because I can already see people on this call like Betty Farrell and Mei Hua, who've been with me, and Jill Steiner on these journeys and know how hard it is to do this type of research work, and just to be open and honest about that. So, and I got to say, I'll point it out, I was in a particularly dark moment about a year ago, and it was right when the PCRC meeting was going on, and it was virtual, and it was so wonderful because it was like, oh gosh, because I was having a lot of trouble with some regulatory challenges, and it was so great to be in this community that was PCRC and other folks who were like, oh yeah, been there, done that. And yeah, you're right, it's hard. So I have no financial disclosures. I'm not going to reference anything unapproved or unlabeled, and my current and past grant support are from these organizations. And of course, I'm very grateful for their support. And we're actually going to talk about that in some detail. So I'm going to talk about past experiences designing, funding, completing palliative care clinical trials, particularly in cancer surgery, and kind of try to give you some lessons learned and wisdom gained. And everything always starts better with a vignette. So this is a real vignette. And when folks say, why, how did you get into the work that you do? Why do you do what you do? And it's exactly because of patients like this. So this was my very first year as a ICU attending. I worked exclusively in a cardiac surgical ICU, and I met SC. So he had a longstanding history of idiopathic heart failure. He had gotten an LVAD, which he had done very well with as a bridging LVAD. In October of the year prior, and then he had his heart transplant Valentine's Day. So LVAD in October, 4 months later, he got his transplant and nothing went well after the transplant. He came out on mega doses of vasopressors. He ended up, he had a balloon pump. He ended up ischemic, getting his one leg ischemic. He needed a BKA and then an AKA. He never woke up. He never really woke up. He had multiple non-healing wounds. He had, his heart did great. The rest of his body fell apart. I met him in September. So he had his heart transplant in February, and I met him in September, and I cared for him many weeks up until he died December 23rd of that year, so 10 months after his transplant. And a lot of the ICU attendings didn't round to him because they said, oh, he doesn't have any needs. It's just the same every day. And I was like, my gosh, this patient has the biggest needs of anybody here. His family were trying their very best. They were lower health literacy, and they kept worried that he wasn't waking up because of the medicines we were giving, particularly the sedatives. And so they would fire nurses who would give him sedatives. So he would do what we would call crying without tears, where he would writhe in the bed in what seemed to be horrible pain. And our hands were tied in what we could give him to mediate that. I would have nurses calling me. This is before I was a palliative care doc, calling me on the weekend going like, something's wrong. This is horrible. I don't think I need to tell you the moral distress was just through the roof. And I met with his family multiple times, and they said, oh, you know, he just never wanted to waste away in a nursing home. That's what he didn't want. I thought he's wasting away in an ICU. Why is this so hard? And that really, cases like this drive what I do. And if you really want to know more about this case, it was actually published in the Wall Street Journal because this patient was the 5th most expensive patient in Medicare that year. So if you really want the details, but this patient, because of this patient and how much moral distress that was around this case, they had a special day to promote palliative care, even though there was no palliative care service where I worked. There was nobody we could have consulted. They did not, it would be actually 3 years before there was a palliative care service there for surgical patients where you could consult them. And they brought in Rashi Joan Halifax and this gentleman, Jeff Dunn, to do a day of discussion about the moral distress and how hard it was to care for this patient. So Jeff Dunn, that's when I met him. He was at the time the chair of the American College of Surgeons, Surgical Palliative Care Task Force. He's a surgeon, became a palliative care doc. He's now retired, although he was one of the AAHPM, I forget the exact award, but he won the award for career physician 2-3 years ago. I think it's the one that Balfour Mont won this past year. But yeah, I mean, there's a whole community of us who care about critical care and surgery, who are the disciples of Jeff Dunn. Wouldn't be here if it wasn't for Jeff Dunn, and I wouldn't be. So I was meeting with Jeff, and I was in the first year of my PhD at the time, and he's like, hey, what are you interested in? And I said, oh, I'm interested in long stay ICU patients, communication, supporting families. He's like, oh, you mean palliative care? And I was like, oh no, Jeff, no, not palliative care. I'm talking about more than end of life care. And Jeff kind of rolled his eyes and he's like, Rebecca, that's palliative care. What you're talking about is palliative care. I had never met a palliative care clinician. I had never done a rotation. I had never, nowhere in my training was there anything about palliative care. And Jeff really mentioning it was the first time I had heard of this. And I went and looked more into it and was like, oh my gosh, this is exactly what I'm talking about. This is exactly the community I'm wanting to be in. And I'm grateful to Jeff every day for that. And so when I wrote my PhD dissertation 3 years later, oh, oops, it was on palliative care. So that's really what has driven me. And I'm a clinical researcher. I've always been a clinical researcher, and I've always been really interested in palliative care clinical trials. And so just to kind of put them all there on one slide. So there may be more out there, and hats off to Tom Smith. It's him who gave me the idea of the slide like this. This is based on one that he put together and that I've maintained. But when you're putting together all of the different trials, clinical trials, of palliative care, specifically, a lot of these are specialist palliative care, and kind of what's done. You know, there are survival benefits in some, across the board benefits in patient experience as well as caregiver experience. Oh, and when you happen to measure cost, that happens to improve cost. As Tom always says, palliative care is better care at a cost you can afford, i.e. it's less. And when you look, over half of these trials, about 2/3 of them are in cancer. A lot of the clinical trials we have done of palliative care for a variety of of reasons have been in cancer. So I really want to start this talk with a little bit like, how do you fund trials like this? And maybe I'm showing my age, although I did read this book to my kids, so maybe it's not just a work of the 70s, but I always loved the book of Are You My Mother? Where the bird's going on asking like a steam shovel, are you my mother? The dog, are you a mother? And I feel like, especially when you are starting as a researcher, you're looking around going, are you my funder? Like, where do I get funding? I want to do research work. How do I do this and such? And it does feel like you spend a fair amount of time going around to other people like, are you my funder? Like, are you going to give me money for this? And at least when I'm talking with mentees, I think I like to conceptualize funding in kind of 3 different buckets. And it helps me when I'm thinking about the project and what I want and where I am in my career as far as which bucket I go to. So kind of 3 levels. There's the local level. And I'm going to go into more detail on these. There's the national level, but specialty specific national level. And then there's the broad national level. And I'm going to try to give you examples here just of my own funding, just so that you can see kind of like, hey, how did at least one person do this? So when you're thinking about local funding, this is usually intramural funding. It can be less than 40,000. Sometimes you can get up to 100,000, but it's typically for your institution, particularly if you work at a place with that supports research. It's pilot funding for some. It is less competitive to get because you're just competing against people from your own institution. Your department may even have pilot funding and seed funding, and then you're only competing with people in your department. But having said that, the dollar value is not as much, and often you cannot fund your own salary. Sometimes there are explicit rules that you can't fund your salary, which is challenging as a researcher. And there were many years in my life where I said, if I can't pay for some of my own salary, I can't pay for myself, and I wouldn't go for that funding. Just to say this, and maybe this is coming now that I'm a department chair, I'm explicitly aware of this. Always be aware if it has required protected time but doesn't pay for it, because sometimes awards like this will say, hey, I know because we just funded one for a faculty member in my own department where it doesn't come where they're paying for the time, but they are requiring the time. And so it requires cost share from your department. So just be kind to your leaders when you're going for this. Let them know about it when you're applying, rather than, hey, I got the award, yay. And they're like, wait, how much money am I supposed to be giving? Although most times they will require a letter from your chair or your chief saying, I agree to support this funding. But it's good to speak with folks, but local funding is great. Oh my gosh, it's great for seed funding, for pilots, particularly if you already have some of your own salary protected for any of various reasons. I actually did more local funding once I became a division chief, because then I actually had some protected time with my division chief and I needed individual projects funded. So, I mean, I definitely had funding from different places that I worked at the time that was local intramural. So it's good to know about it, be aware of it. And I put that in a different place in my mind than funding that is national but specialty specific. So this is extramural funding. It's often more at the 40,000. That's like an RO3 level, up to 200,000. But you know, specialty specific. It's more competitive than your intramural funding. Definitely, it can be career development. It can be project pilots. You know, in our palliative care community, this clearly would be NPCRC funding. And NPCRC through the Kornfeld Scholars does career development for many years. Up until a few years ago, they did pilots as well. If you're a cardiologist, the American Heart Association, National Cancer Society, if you're an oncologist, some of these are quite competitive, but it's certainly more competitive than intramural, and can be very prestigious as well. Oftentimes you can at least partially fund your salary. If you're on a career development award, often that's required. It will require cost share with your department again, but you can actually be paying for your own salary. And these are a great launch. These are really important, I think, as you are a researcher and trying to establish yourself. So just speaking for myself, these are some of the specialty specific funding I have. Everything from like funding to go to conferences from FAAHPM or their research scholars program that enables folks to go to the Kathleen Foley retreat. I'm an anesthesiologist, so FAIR, Foundation for Anesthesia Education and Research. That is a huge funder if you are a researcher in anesthesia, particularly if you are a junior researcher and wanting to get a foothold. And PCRC, the Gordon Betty Moore Foundation, these are just people that have funded me. There are more out there. The PCRC has had pilot funding, that falls under this too. So these are important, and I'll think about particular projects, particular phases of careers where this is a good place to go. And then there's the broad funding, and this is extramural range of funding. This is wise advice that was given to me: if you're doing the work, you might as well go for the bigger funding. I remember early in my career where I was like, should I do an R04 or an R21? I'm not quite ready for an R01 yet. And I remember a mentor saying, the R04 is as long as the R21, but yet the funding is a quarter. So you might as well go for the R21. I did apply for an R04 at one point because I applied for a Gemstar, but which I did not get. But just think of that, because these are long applications. Even if you're going for a small dollar value, they're long applications. Very competitive to obtain. You can get career development like a K award. You can get pilot funding with an R21 or an R04, or PCORI has kind of similar things, or you can have a full project or something like a U grant that is funding projects, so multiple. You can fund salary, you can fund salaries, multiple people off some of these that are larger. And oftentimes if you're thinking like, hey, I'm a full-time mature researcher, I want to be a Joan Tino, I want to be a Jennifer Temmel, like, I want to be a Sean Morrison. A lot of these folks are carrying 2 to 4 of these concurrent awards at any one point. For somebody describing to me, if you want that I'm a full-time researcher cadence, you are putting something in every NIH cycle, everyone. I think Randy Curtis, who I will mention later, definitely, he and I talked about that multiple times. So what is this? This is for me. I've been mostly funded by PCORI, thankfully, for my career. I've had 10 years of continuous funding from them because the type of work I do fits what they do quite well. I've also had ARC, but of course, the gorilla in the room here is NIH. This is your NIH funding. So it's really important. These are very competitive. It's pretty much essential if you're going to be a big gun researcher that you're carrying some funding like this. But I put it in a different place in my brain than the specialty specific and different than the intramural. And I'll very much try to match projects. So in my mind, I have a new project. I need pilot data. I want the R01 3 years from now. I'll put in for intramural funding, try to get 40,000, 100,000 to fund my 1-year pilot, my 2-year pilot that gives me the preliminary data that might be able to get me to the R21. If I'm really good, it'll get me to the PCORI or the R01. But many times that gets you to the R21, and then you can really do the good pilot for 2 years, and then that gets you the preliminary funding that gets you to the R01. So you can see how you can kind of step your way through some of this. Or you get the pilot funding from, say, American Cancer Society, and then that can leverage in. So that's how I think about funding in different kind of places in my brain. So I'm trying to use my own examples here so you can see kind of what this looks like in real life. So my first like major award in R01 equivalent was PCORI award, and it was to develop an advanced care planning tool for major cancer surgery. So how to help patients and families and their surgeons and their perioperative team members have meaningful discussions before they go for a big surgery. And this came from, I had a mentored research training grant from FAIR, and that pilot data from that 2-year grant gave me the preliminary data that allowed me to get this award. So just to kind of put the funding in perspective. We did this for 4 years, and we did a lot. I could do 3 talks on everything we learned from this. We had to develop a video-based advanced care planning tool that had never existed in surgery. We did an RCT with this. I get a lot of folks who say, how do you do this type of work? What do these teams look like? So just kind of in this bottom right photo, if I'm starting in the back in the woman with the, on the far left with the blue shirt, that's a surgical ICU nurse. Then for folks who know behind, I'm going to go clockwise here. That's Angelo Volandis, who's well known for advanced care planning videos. That's Jake, his videographer who works with them. Study coordinator, John Bridges, who is a study coordinator, who's great. He works, I believe, at Duke now. John Bridges, who's at Ohio State now, who's a healthcare economist. Sandy, who is a SICU nurse. Matt Weiss, who is a cancer surgeon. There's Jeff Dunnigan, because he helped us with other projects once he and I had met. So a surgeon as well as a palliative care doc. Then there's a patient family advocate. There's Tom Smith, an oncologist. Flipping to the front row, right to left. Yay, anesthesia resident. Always bring your trainees with you. She was doing research time with us. Then there's a family advocate, a patient advocate, our funder, and then you can see a younger version of me with shorter hair. So that's the kind of teams that you have when you do work like this. And these interprofessional multidisciplinary teams are absolutely essential to do the work like that, like the kind of work that I do. So our most recent task, and this was the late breaker at the anesthesia meeting this past year, and it's embargoed, so I can't say where, but look for your emails a week from now, because this paper is going to land May 31st, so next week. Which is our findings from a pragmatic multi-site RCT where we integrated specialist palliative care into the perioperative period. So we did the advanced care planning video. It didn't, in our pilot trial, it didn't show an effect. People liked our video. Nobody's head popped off, which in surgery is important to say, hey, we integrated advanced care planning. There was no harm, because there's still that culture of like people being concerned about palliative care things. There was no harm. People thought it was beneficial. We didn't see an effect. We audio recorded conversations between patients and surgeons, and it hadn't changed. And when we went back and did qualitative, surgeons said, you know, I kind of got my spiel. And whatever our hypothesis had been, we're going to activate the patient and family. They will come in activated, and that will change the conversation. And it didn't. And when we went back and we're doing further qualitative for it, we had some patients and families saying, you know, I don't want to have this conversation with my surgeon. And concurrent data came out in medical oncology asking patients, who do you want to have conversations with? And about half said, oh yeah, my medical oncologist. And the other half said, anybody but my medical oncologist. So we really leveraged that and did focus groups and stakeholder summits, and really landed on who should it be if it's not the surgeon, and said, well, how about a palliative care clinician? And that's how we ended up with this. And we always laughed because Jennifer Temmel is one of our consultants on it, but this was the Temmel trial taken out of MedOnc and put lock, stock, and barrel in SurgeOnc. So, and in upper GI cancer surgeries. So our prototypical patient had pancreatic adenocarcinoma. They were going for a Whipple, and they were randomized to either surgeon alone or surgeon palliative care team co-management during the perioperative period. And just like Jennifer, we measured health-related quality of life at 3 months post-op, and hypothesized that there would be a difference with palliative care co-management. Yet again, you have to have diverse teams to do work like this. So I was at Stanford at the time, so you could see me with the Stanford group. Each team, and we're going to talk a little bit about governance, each team had a site PI, a lead surgeon, a lead palliative care clinician, and a lead patient family partner. And our 5 sites were Stanford, Hopkins, University of New Mexico, the Dana-Farber, and Ohio State. So just put this in perspective. So that FAIR funding I initially had. So first I had a T32 right out of fellowship. So I had 2 years of funding with the T32. I was off funding 1 year. And then I went on a FAIR grant for 2 years. That was a mentored research training grant. And that provided me the preliminary data that allowed me to get the first PCORI award. And I got a very good day. I got a K award and the PCORI on the exact same day. We were at Disney World that day, and the joke was, you just got a K award. I'm already at Disney World. So, but it was a very busy day because it was the first day of a vacation. And it turned out to be a little less vacation that day and the next day, trying to figure out what to do. But so that preliminary got the data for the PCORI, that first PCORI surgery, and those data were the preliminary data for the multi-site RCT of a different intervention. So just trying to put this in perspective, this is over 15 years. So your projects do build on each other, and it's not, they don't exist in a vacuum, and ideally you're trying to leverage off previous funding to help you with further projects. So those are trials. I'm going to put that aside as far as my own work, and then go into a little bit of like when you're designing these trials, how to think about it. And some of it's important for you when you're presenting your trial to other people, and some of it's important for you to know so that you know how to cast it to funders. And also too, so you can explain a little bit of what's going on and why you might be having trouble with your trial. And this is particularly important, I found, in cancer trials. So study design, are you explanatory? Are you pragmatic? For folks where this is a review, I apologize, but I think it's important to bring up. So explanatory trials are really like, does X do Y? If I give somebody a statin, will their cholesterol decrease? It's really about cost effect. It's efficacy. It's efficacy trials for that intervention. You want to have very rigid protocols with everybody very much the same, because you want to see, does the drug or does the device do what I hypothesize that it does? So efficacy trials, explanatory trials. Pragmatic trials are, does the treatment work in the real world? Not does a statin decrease people's cholesterol, but can I give statins to a population and they're tolerated, and the cholesterol level for the population goes down. So they're different trials, it's a spectrum, and I'm going to go into this, but it's important for you to know what trial you have when you're going to funders, as well as so you understand how to integrate it in your own institution. So explanatory pragmatic, this is a tool I find really helpful. It's the Presses tool. You can see the reference there, as well as the journal link, the web link. And you essentially grade your trial from 0 to 5, and 5 is the most pragmatic and 0 is like the least pragmatic or the most efficacy. So like, how are participants recruited into the trial? Is it really loose recruitment? That'd be like a 4 or a 5. If it's super strict and it can only be this type of cancer and this age and this grade of cancer and such, then it may be more of a 1. So you grade that as you go around the circle. So this is kind of what it looks like when you do this. And you can see panel A is a very pragmatic trial, very much explanatory, while B, I'm sorry, very much pragmatic trial. It's not efficacy, it's explanatory trial, it's a pragmatic trial. While B is efficacy, it's you know, does the thing work? Does the drug work? So like with the trial I just mentioned, our RCT, we had diverse real world patients and practitioners, clinical care settings. I mean, they had to be able to offer these surgeries. These are big upper GI cancer surgeries. Our broad inclusion criteria, we laughed, we said, you know, it used to drive, it drove the cancer centers nuts, because they like they're used to very specific inclusion criteria. And we're like, do you have a cancer from the mid-esophagus to the ligament of trites? We'll enroll you. Like, you know, like, how many hepatocellular carcinomas? We're like, we don't know. We don't know how many we're going to enroll. We're a pragmatic trial. We had essentially three criteria, really, two. Do you have a tumor between the mid-esophagus and the ligament of trites, primary tumor? Are you going for curative intent surgery? It's going to have those two, curative intent surgery and a tumor there. And have you not seen a palliative care subspecialist before? Those were our 3 criteria. That was it. And we did not protocolize the palliative care content in the clinician arm. So people in the palliative care treatment arm, we did not protocolize that. And that's a whole separate conversation, because that was a very cognizant decision. So that's like where ours came out, we thought. So just helpful. So we are more of a pragmatic trial. And it's helpful for you to know what you are. Also too, think about your level of randomization. Is it individual? Is it by provider? Is it by institution or site? Going into details. So like with the trial I just showed you, our multi-site RCT, we initially went to the funder as an individual randomized trial, and they came back and said, we'd really like you to have it be randomized by surgeons so that there's not contamination. Any surgeon, all of their patients will either be palliative care surgeon co-management or surgeon alone. And we went back and said, you know, there's not a lot of surgeons at these hospitals that do these types of upper GI cancer surgeries in enough number that we could enroll them. So we can't really enroll surgeons. There's only 1 or 2, maybe 3 at a place that does a lot of these, but most times just 1, maybe 2, you know. And so this really means we'd have to randomize by hospital, not by surgeon. And are you ready? I mean, we did the numbers. We're going to be probably like a 14, 15 site trial, you know. And PCRC came back to us and said, this hasn't been done before. This has never been done in surgery. We're not ready to drop, you know, 20 million to do a multi-site trial for 15 sites. And they said that, you know, why could you be individual? And then we brought back data, and these were data from one of our sites, University of New Mexico. So they actually did a retrospective review of 107 patients who would have qualified for our trial. They were getting pancreatic cancer surgery, and they 47% of them met NCCN guidelines that they should have been considered for palliative care consultation. And we looked and said, look at this, only 1 out of this 107, only 1 got palliative care. So we hypothesized that we could individually randomize, because we were starting with very little penetration, and we would be able to detect contamination by looking in the control arm. And you can read the paper when it comes out next week, because that's something that we did have to do. And we had very different contamination across different sites, with people in the control arm essentially still getting specialist palliative care. But this is what we had to bring to the funder. So this discussion about level of randomization, that was absolutely a negotiation we had with PCRC before they funded us. So it's important to know that and to think about that when you're designing the trial. You absolutely live and die by your outcomes. They have to be measurable. And I'm going to give you an example. Validated is really good. you live and die by your outcomes, you have to have discrimination and responsivity. And I'll show you an example of that. If possible, you want to have in your target population, your outcomes used. It's great if you could use them in a pilot trial, or at least use something that's been done in a previous palliative care trial that has shown responsivity and validity. So I'm going to give you an example. So I do work in the ICU as well. And I get a lot of folks saying, hey, like, let's do a trial of palliative care in the ICU and we'll see whether it works based on family satisfaction, because we're going to roll out this palliative care intervention and family satisfaction is going to go way up. And that's how we're going to know that that this is working. Family satisfaction in the ICU, despite really amazing people doing work psychometrically in this outcome and field, is really problematic. So this is a systematic review we did almost 10 years ago now. And it's been updated now as well. Matex et al. It came out year before last. But here's family satisfaction as an outcome. So we had 14 different trials that used it, over almost 5,000 patients that were enrolled, and yet it was only responsive in one trial of 88 individuals. So one smaller trial. It's not a responsive outcome. It's not a discriminative outcome. The issue is it has a bad ceiling effect. There's a couple of different measures. There's family satisfaction in the ICU, critical care family needs index. There's a couple of outcomes. FSICU is the one most often used, but and it was used in a lot of these trials, but it has very poor discrimination. Everybody starts at about 80% satisfied for a variety of reasons, and I've written about this. 85% satisfied. You can't show improvement if you're starting at 85%. It's really hard to improve on that. It's very hard to power anything to improve on that. So it's not a good outcome for that reason. So that's why you really need to think about your outcomes. And face value, you look at the family satisfaction in the ICU or critical care family needs index, and the face value for the items looks great. Like, oh, this is exactly what I'm talking about. My intervention is really going to affect this. But there's no discrimination. So the face value for the items may look good, but as an outcome measure, it's really problematic. So like, what did we do? We used the outcomes that Jennifer Temmel used. So, because we said, hey, this has been used, we used FACT-G, FACIT-PAL was our main outcome. And that has been used in multiple palliative care trials with discrimination. We initially proposed using hospital anxiety and depression score and PHQ-9 for our mood outcomes, because that's what was used here. And we had preliminary data in our own patient population from that PCORI surgery one showing variation in HAD scores during the peri-op period. So we chose those outcomes based on that. So you really do need to think a lot about your outcomes. Pilot trials showing that you can collect these outcomes and that you can have discrimination, that's key. IRB, just know it can take months to get through the IRB for especially a big trial, so just build it in. And if you're doing a cancer trial, there's often 2 IRBs and they don't work in parallel, they work in series. So your trial goes to the IRB, it then goes to the cancer center where it's reviewed, put maybe a month, 2 months, 3 months, 4 months. I've had stuff sit there for 6 months at one place, and then it goes back to the IRB. So just build in the time. It takes a lot of time, particularly for cancer trials, and be ready. A lot of IRBs do not understand palliative care trials. I have definitely presented at cancer centers. There was a trial I was doing that was really just a qualitative study of women around the time of their gynec surgeries, exploring their spirituality needs. I mean, it was a qualitative study. It took 7 months to get through the IRB because I had to go through the cancer center first. And when you went there, I had to go to an in-person meeting with their review board, and they said, well, what if you're asking about spirituality and it upsets people and such? And, just these were not built for our palliative care trials, and I always say it's the double-edged sword of working in palliative and end-of-life care. Everybody has an experience. Everybody has nearly everybody has some family member or friend or somebody where they have a personal experience about it. So it matters to everybody. So that's the good edge. The double edge is it matters to everybody, and a lot of people will have thoughts and feelings, and they may not be aware of what is the state of the field. And I was absolutely on a call with a funder, with James Tulsky, where we were running into that problem, and he's emailing me back going, this person just doesn't understand palliative care research. We don't need to, when they're asking, like, are you going to be able to get this through an IRB? Like, people sometimes really just don't understand us and what we do, and you just have to have a lot of patience and be ready to positively and patiently educate, because you could be like, I got my funding, like, oh, I got my funding. And then suddenly you're having a really hard time getting through the IRB. And it does feel like this, like you finally have your funding, it's great, but there's a lot of barriers that can exist. And a lot of the cancer world was not built for palliative care trials. You are always the square peg in a world of round holes, and it can be very frustrating sometimes. Number 2, data use agreements. These allows data to pass between institutions, including PHI. It's essential for multi-site trials. You can't have multi-site trials without DUAs. Just know that they can take weeks to even months to arrange. And some places, I will not name names, of the 5 places in the trial I'm just finishing, one of them had a really funky DUA, and it like affected us. It still is affecting us as far as what we can do and what data can be shared. So just, and including for regulatory reasons. So just be aware of DUAs. Consent, there can be written, can be verbal, there can be a waiver. Know that what's acceptable can vary between institutions. So you may even have a single IRB, but you may still have sometimes some challenges at individual places. It also can change over time. We had great discomfort. We knew what consents we used and everything. And then halfway through the RCT that we just finished, the COVID pandemic hit, and what was allowed for consent got completely thrown up into the air. And we ended up having 15 people that we had enrolled that eventually one of the IRBs said, we thought this was appropriate consent, but now we're not so sure because it was a verbal consent. I mean, hopefully we won't go through a pandemic like that. I hope not anytime soon, but that we couldn't use because we thought we were following the consent guidelines. And then it changed a little bit as people settled out with what was allowed in the post-COVID world. So just be aware and check with regulatory groups. And if you have a coordinating center, that's usually the bottom line. And a lot of places look to the coordinating center to help them understand what's allowed and such. So just have them in the loop. Do you have a DSMP? Do you have a DSMB? So there was an article, Jennifer Temmel, and I think James Tulsky was on it too, that came out 3 years ago that said, always have a DSMB. It was like, that would have been nice to have known 4 years ago, 5 years ago, because we had a DSMP. So what you have, so a plan means this is how we're going to manage our data safety. This is how we're going to follow things and such, and you organize it in advance. A board is, we are doing this, but we have people who are going to check up on us. So like that first PCORI trial I had, we had a DSMB because PCORI required a DSMB at that point, even though we were a low risk trial. For the RCT we just finished, we had a DSMP. P as in plan, initially because PCORI didn't require the B anymore, and we figured, oh, we're a low risk trial, like things are hard enough already. Why make things harder? I really wish we had had a B because that might have helped us later on. But just be aware of what are the funders, what are the rules and regulations of your institution. If you have a DSMB, be very thoughtful about who you pick. It's not just kind of, oh, this person, that person. They really should be not in your study at all, but somebody who knows about your subject material and who can comment on it. And I always am a big advocate for having patient and family member partners in your DSMBs because they really can provide valuable perspective. And we could have a whole separate talk about patient and family engagement and how you find somebody and how you pick them and the different types of engagement and such like that. So I'm a big advocate for it. Okay, scars coming. DSMC. So this is a committee that can exist at many cancer centers. They review all cancer-related trials. I'm just speaking from my own experience. This was the hardest thing for the trial that we finished because they were built really for explanatory trials of efficacy trials for high-risk, high-mortality drugs, technologies. And it's really hard when you're a pragmatic trial exploring effectiveness of a low-risk intervention. Talk about square peg, round hole. Oh my goodness. I'd been at 2 institutions. The first institution I was at, the DSMC, they never got in our way at the cancer center, but we went through audit because we always go through audit, and they asked a lot of questions, but we settled it. It wasn't an issue. And then the second place with the trial I just finished, I mean, they put us on hold multiple times. And they'd say, we need your pill diaries. And it's like, we don't have pill diaries. We're a palliative care trial. They would ask for stuff that just doesn't exist in palliative care trials. And then they'd get frustrated when we didn't have it. And it was very hard to have conversations. And I mean, at one point I had to, I got sent to get remedial training in study design because they thought my study was not designed the way it should be. And I had somebody telling me that I didn't understand that palliative care really is dangerous. It's very dangerous. And I'm looking at this person going, can you tell me about palliative care trials. Do you know what it is? Like it really tested the patients on a regular basis. And I know some folks on this call watching were with me along that journey on some of the way. This was absolutely one of the hardest things for me personally. Just, that some of them may have very little experience with palliative care trials. Be prepared, patiently, clearly, longitudinally educate. People are trying their best. They're being asked to do something. They are there for the trial often, or my experience was, they're there for the trial of the really, really dangerous chemotherapeutic that absolutely could kill people. And they need to be super vigilant for that because people can get hurt. And when you're coming in as a palliative care trial, especially if you're of a low risk intervention, you're not what they're used to seeing. And it's that square peg round hole world in stark relief. So governance, important to know the governance of your trial. It's important for you to know it. It's really great to have this. Many grants will not get funded if you don't have a governance plan. So like this was the governance plan of the RCT we just finished. We had a central structure with an executive committee. And you can see, I mentioned this before, a study PI, lead patient family partner, we had a biostatistician, we had some other folks because that was the lead site. But every other site had a site PI, a patient family partner, a surgeon partner, and a palliative care partner. So think about the governance of your studies, and it's important for you to know it. And it's also important for you to be able to say that to funders. And if you have problems in your study, you need this governance to know how to move things through. So I showed you one plan. There's other advisory groups that can help in governance. You can have steering committees. You can have stakeholder advisory boards, professional advisory boards, community advisory boards. You can have a publications committee or a group authorship guidelines group. You can have your DSMB, that definitely can exist. We had an expert advisory panel in EAP, probably because we did not have a DSMB. And with COVID, we ended up needing an external advisory panel. And I'm very grateful to those individuals that did the work of what a DSMB would do. So note to myself, I'm doing DSMB every trial now, but live and learn. Finance and legal, this is your business. I've had a few folks who are like, oh, I've got my finance person. I don't have to think about that at all. That sounds fabulous. I have never had that. They often change. They can be they can change. You are sometimes the only source of project history, especially for a multi-year project. And if you change institutions, get ready. I find this to be the least able to be delegated task. And especially in a multi-site trial, you have thousands of dollars leaving and going between sites. And once it leaves the coordinating center, it's almost impossible to get that money back. And I caught mistakes multiple times that were not malicious mistakes at all. It was, oh, I didn't realize I didn't realize that was last month's numbers, or oh, this was the enrollment plan from last year, but not this year. And so it's important for me to look at those invoices. And if you have a legal person who completely owns it, great, more power to you. I've never had that legal person, so I've always had to look. Remember always the difference between direct budgeting and indirect. So direct is what you can budget. So your subcontract directs always come out of your main directs, budget for them. If I have money going from my institution to the sub-site, that's the directs. Indirects are what go to your home institution. You can't budget for it. So like a PCORI award, a traditional award is 1.5 million, but 2.2 million changes because that 700,000 is the indirects. 1.5 million of the direct, 700,000 of the indirect. But where you get into trouble is when you have a multi-site, the subcontract indirects sometimes come out of your directs, and sometimes come out of your indirects. And it varies, and it sometimes varies up to a certain dollar value. I've been there, I've done that. I can show you the scars where I did the budgeting wrong because I misunderstood it. Get into the weeds. If you have a great finance person, they can help you with this, but yeah. So milestone-based budgets versus block funding. Block funding, they get a set amount each month. Whatever happens, whatever they do. Milestone-based budgets, they get paid on completion of tasks. Like, did you get your IRB done? A big one is for multi-site trials is per enrollee. I started the RCT on block funding and had to switch to milestone-based budget in the middle. And I strongly endorse milestone-based budgets because people can have the best of intentions and yet stuff doesn't get done. So just to kind of take this home, so study progress of the study we just finished. So we started enrolling at our first site in October 2018. Yay! Dory was our creature that we found encouragement from, like, just keep swimming, just keep swimming. Hey, mid-19 enrollment at 4 sites. We're rocking and rolling. Oh, we're swimming great. Oh, and then the COVID pandemic hit. And enrollment ground to a halt everywhere and only slowly started to pick up and never got back to what it was before the pandemic, but we were enrolling again. We started at a 5th site because enrolling was challenging after the COVID pandemic. And then finally we enrolled our last study patient a little over a year ago. Yay. And so, and this is public because I presented this at our the American Society of Anesthesiologists meeting last fall. We were the late breaker, so the abstract's been published and such, but there we are. We're now a palliative care trial, still in cancer, but in surgery. You can see, you can read the details. We don't look like some of the other trials and some of what we hypothesized we did not find, but read about it next week. So what I know now and wish I knew then, trust but verify even amongst friends. That gets into the block funding. It doesn't always work. Monthly enrollment audits, at least twice yearly. Missing data audits, better you know about it beforehand. Oh, so many scars here, than having it found. So be proactive and look for things. I already mentioned about the fine print for directs and indirects, especially when it comes to subcontracts. Know that you'll do everything right and there will still be problems. Scaffold, automate whatever you can, weekly project manager meetings, data updates, weekly meeting minutes, like absolutely scaffold it. You have meeting minutes every week because it's important when you're reporting back afterwards, especially for regulatory reasons. Build the infrastructure, just be ready. There will always be regulatory documents. You will always be under some sort of audit. It can be from the funder, it can be from the institution, it could be from the IRB, it could be from the DSMC, it could be from the IRB at one of your subcontract sites. So just as soon as one ends, another starts, just be ready. You didn't do anything wrong. This is just the cost of doing business. Keep your experienced experts close. Don't be afraid to phone a friend. I am so grateful to Jennifer Temmel, to James Tulsky, to Tom Smith, who were always senior people on the trial that I could call, especially Jennifer, and just say, help me with this. Like, I don't understand. And it's really important to have those folks who've done it before, even if they're an arm's length from your trial, but who can be a reality check for you. I've been very lucky and I've had wonderful program officers in my career who've been very helpful with problem solving, especially like COVID pandemic, enrollment challenges. So just know that they can be a good resource. Just know this is really hard work, and our catchphrase that there's going to be Barbie days. And I'm a child of the 80s and 90s. And in the 1990s, there was Teen Talk Barbie, and it was like such a big deal because she talked and she said, math is hard, let's go shopping. And I don't think I need to say for a lot of reasons that was problematic, but we still tease that there's Barbie days because research can be really hard and you need to just acknowledge that. And like going out to eat, like, is really important, or doing something to help you decompress, and doing fun things with your research team so that you remember that you're humans and you're doing cool things and what you're doing is really hard. So big time gratitude, of course, and it's still hard for me to get through this without tearing up because I miss Randy so much. But I wouldn't be here if it wasn't for him as a mentor. And he was always one of my expert consultants. So I miss him. Work with people you like, maybe even love, was his phrase always. And I've been so grateful to have just amazing people to have worked with just on all my trials, but particularly the trial I just finished. 32 people on the final publication across 25 different divisions and institutions and such. So it really takes a village to do work like this. You know, participating, everybody, trials, the family members, patients, clinicians. We had amazing site coordinators, project managers, family, friends. I always laugh that this trial was like my third child and such. Our external advisory board, I mentioned, professional advisory board, just our funder, Palliative Care Learning Network, and of course the PCRC was a big part of our trial. They have been partners with us the whole way through. Katie Colburn was our main biostatistician, and I am grateful for her so much. She did a wonderful job. Shelby was a master's student, worked with her. Rachel Kendrick, I know, is not at the PCRC anymore, but she was with us for many years, and I'm really grateful for her input. And that's all I got, and I welcome questions, and we've got 10 minutes left for discussion.
Thank you, Rebecca. That was incredible. What a great opportunity to think through the ins and outs of all the challenges that one faces in trials. And maybe, Naomi, you can just put the slides down for just a minute so we can do the questions and answers. So I'll start with a question and answer while we hopefully hear from other people. And that is, you have been working with a lot of people. There are a lot of folks that you have to communicate with, coordinate with, the pictures that you showed at the end, the authorship, etc. What are your tips or pearls for people about how to navigate very large teams?
Automate, scaffold. It's much better to proactively communicate than to wish that you had. So when you're building, at least for me, I would recommend, especially for a multi-site trial, build in the scaffolding that we had every trial I've run, we've always had a weekly meeting for the project managers, the research coordinators. So our lead research coordinator would host it, and she was the leader for that, and that was weekly, and that's where there would be minutes at the meetings and such, so you're keeping track of stuff. Were there any problems this week? No. Any consent issues? No. Any, so you're boxing all of those things, and it's just built in. You don't have to remember it. You don't have to think about it. It's in the works, and you've essentially outsourced it to your project manager, although you're going to need to help them to build that. And I would go, especially early in a trial, I'd go to every Friday meeting as the PI. And then a little bit later, I would, especially when enrollment's going and such, I wouldn't go necessarily to every Friday one, but then we had before we started enrollment, we had weekly meetings with the site PIs, because that was an intense time, like, where are things in the IRB? How are we moving this through? And then we switched to monthly once the trial started going. So automate things, better to schedule more than you need and then scale back than to try to wish you had scheduled more, and then just scaffold it on out, minutes at the meetings, and then you could have a central website if it's needed. We had a central repository, so if any of the sites needed minutes or needed anything, they could go to our main research coordinator, who would say, oh, like May 24th, 2019, here you go. And we evolved into this. I wish I could have started this, because this is because of lessons learned with some of the regulatory challenges we had, where we wished we had documentation for some of this. And then we started to build that documentation so that it was there when we needed it. So some of this was reactionary. And if I had known more, I would have built it proactive from the start.
Great. Very good tips. So a question for you, as an early career person trying to gain skills in clinical trials, what are the practical training experiences you recommend to complement didactics and courses? So
great question. This is where phone a friend can be really helpful, and sometimes even just following along as a junior person, like, how can I get involved in this trial or such? So like, and then learning from that. So like at one of our sites, the PIs were more senior people, and early on they said, hey, there's this a junior person who's really interested in palliative care research, and they'd really like to be more involved. Can they start sitting in? And they started to sit in, and they actually became the site lead for that. And they are now the main person on publications. Like, they actually got really involved. So, and that started with that person going to somebody saying like, hey, what trials are going on? How can I be involved? So it can be at your own institution, but also outside, if that's where, like, PCRC, FAAHPM, research committee, early investigator committee, that's where networking comes into helpful. Like, what trials are going on? How can I be involved? And starting to build some of the relationships, because some of the best things is really fly on the wall, and learning that. And you will still, like, lumps and bumps, you'll have your own scars. It's hard to do this work, and you will learn along the way. So also then giving yourself grace that it's not like you're totally and completely prepared. Like, you often launch when you've only got a couple engines burned. Oh, and then you build it on the way.
Great points. And the phone a friend, I think that's part of what we all do in palliative care communities. So next question, tips and experiences for finding and retaining great research coordinators. This questioner said, we've had constant turnover in recent multi-site trials, and it's a real challenge.
I couldn't agree more. And you will do everything right, and this will still be a problem. Just putting it out there, because you're often, these aren't super high paying jobs. They're often people who are in transition stages of their career. And so that's inherent, and it's a double-edged sword. So whenever I'm interviewing research coordinators, I'm always trying to understand them as a person. Like, where are you going? What's of interest to you? I'm interested, I want to go back for my PhD in a few years. Oh, cool. Okay, what do you need to do that? Because I'm always looking for ways that we can dovetail, where I'm helping to grow the person and they're fulfilling their own goals and they're on their own journey. And this work is helping that, because I find that first off, they're hungry and you're helping them do what they want. You're listening to them, and you're able to then build things so that what you're doing can help them obtain their goals, and then you can go together. And also too, if then they're more open about those goals, you can prepare for it. So like one of the best research coordinators I ever had the privilege to work with, and she worked with me for 2 years. She was really clear, like, I want to go to medical school. Like, I'm planning to go to medical school. I'm going to go there. So we knew, like, she wanted to go to medical school. She worked 2 years for us, did amazing work. And we made sure that she had exposure to clinicians, and she was doing things that enabled her to have a strong medical school application. And we knew when she was likely to be leaving. And so we prepped and started to look for somebody. So it wasn't like she gave us 2 weeks notice. We had like a year notice for her leaving. So really having that individual level input with the person. Why are you doing this job? What's important to you? Where are you going? And I often cognizantly will choose people who look like they're going to leave in a year or two. If I know where they're going and they're hungry. I love people who want to go to nursing school, want to go to PA school, want to go to medical school, dental school. I love them. They're hungry. They want to do stuff. They know where they're going. And I often have an idea for when they're going to leave, so I can plan a little bit more. I've had some amazing master's levels folks where this is the kind of their terminal degree, but also too, where are you going? What kind of researcher do you want to be? And really trying to understand their journey and draft off each other. Does that make sense? And Christine, you have, I'm sure.
Absolutely. I totally agree. I think finding the right fit, finding what people are interested in, trying to support them on their professional journey, all those things certainly make complete sense. Well, we can't thank you enough for this time with you. Thanks so much for being a part of this community and for really a great overview of all the challenges. I just could commiserate with you on so many. And so really appreciate your honesty and transparency around that. And with that, I'll turn it over to Naomi to give us an update on who our next speaker will be for our next webinar. And thanks again, Dr. Aslakson, for your incredible presentation.
Thank you. Thanks for having me. And I hope folks know if there's anything I can do, please never hesitate to reach out. I'm happy to be a friend, even if we haven't met. I mean, we're all friends in the palliative care research community because we're just not that big. So if I can be of help in any way, please don't hesitate to reach out. And I think I speak for a lot of the senior researchers in palliative care. We want you to be successful. We want to potentiate you. If there's any way we can help, we want to help.
Thank you. Naomi, you want to say who's coming up next in June?
Sure thing. Thanks so much, Dr. Aslakson, Dr. Ritchie, and everyone. In just 2 short few weeks, we have our final PCRC webinar on the state of the science in palliative care with Dr. Sean Morrison. So please don't forget to register for that. It's June 7th from 3 to 4 p.m. Eastern Time. And do keep a lookout for our post-webinar evaluation for today. So thanks so much and have a happy Memorial Day to everyone.
Thank you. Bye-bye.